So we are live, Mahesh. Now I'm going to put presentation, right?
Okay. I think Shrikant, we can start. So
Yes, we can, Mahesh.
yeah. Okay. Good evening, Doctor. I'm Mahesh Marathe on behalf of Zydus welcomes you for the Expert Talk Symposium, an event where medical experts share and discuss their latest medical views. As the prevalence of respiratory infections are increasing day by day, and so the increased challenges associated with the same. Hence, it is essential to understand latest treatment options for the effective clinical approach in respiratory health management. It is our pleasure to have Dr. Harish Chafle as a speaker of today's Expert Talk Symposium. Today's topic is drug review of Faropenem with clavulanic acid in the management of respiratory health. Dr. Chafle is senior pulmonologist at Global Hospital, Mumbai. Sir has medical experience of more than 2 decades in critical care and respiratory medicine. Currently working as senior consultant intensivist and chest physician, bronchoscopist, and sleep disorder specialist at Global Hospital, Parel, Mumbai. With his name, there are various case presentations and publications in journals and conferences. We believe this expert talk symposium will be useful in your day-to-day practice. During today's session, you can post your questions in the chat box. Now, I would request Dr. Harish Chafle to start today's expert talk symposium. Over to you, sir.
Yeah, thank you, Mahesh, for those kind words of introduction, and I thank you, Zydus, to initiate this talk. Basically, because this is a molecule that we are being using recently. Many people have started using many years now, actually. But the knowledge about it, the confidence about it, is still not up to the mark. That's how I think people are not using upfront whenever it comes to using it. So let us discuss about this molecule, and then I think everybody's thought process will be clear, as well as if there are certain doubts, we can discuss at the end of the talk so that things will be clear from everybody's perspective. So with those words, I would like to start today, and I welcome all the viewers who have joined us for this webinar. Uh, we are discussing today about drug review, and the drug that we are going to review today is one minute. Yeah. So drug review of Faropenem with clavulanic acid is what I'm going to discuss today. We all know it all started with beta-lactam antibiotics initially, and penicillin is the molecule that everyone has used in their MBBS days. I still remember using uh, penicillin CP, so crystalline penicillin gentamicin, were our preferred antibiotic of choice when I was studying in the medical school in Nagpur in 1992. So as we all know, beta-lactam antibiotics is one of the most commonly prescribed antibiotic classes with numerous clinical indications, and it shares a common structure. Beta-lactam. Why they are beta-lactam antibiotics? Because it shares a beta-lactam ring, and that is how it becomes beta-lactam. You can see penicillins. So this particularly the ring called beta-lactam is same in all these. So penicillins, cephalosporins, and carbapenems. Now, what is the mechanism of action? Before coming to usage, we should know how the drug is going to act, and then that will be useful for use in the patients. As we all know, bacterial cell wall, it has a peptidoglycan layer, which is important for bacterial cell wall integrity. If the cell wall is not there, then what happens? It collapses, and the bacteria will not survive. So this is one of the mechanisms of action for antibiotics, which acts on the cell wall. And penicillin binding proteins, PBPs, these are the penicillin binding proteins. They play an important role in the synthesis of peptidoglycans, which is a layer that is important for the bacterial cell wall integrity. And what happens then? Beta-lactams, they bind and irreversibly inhibit the penicillin binding protein. You see this antibiotic has taken away these penicillin binding proteins. They prevent the cross-linking of the peptidoglycan layer. There is a cross-linking here, and that is prevented, by which there is disruption of the cell wall synthesis and there is death of the bacteria. This is the mechanism how it acts. So beta-lactam antibiotics, they are bactericidal and act by inhibiting the synthesis of peptidoglycan layer of the bacterial cell wall, which is what you can see in the slide. Now comes penems. So penems class, basically, these are the newest addition in beta-lactam antibiotic armamentarium. It's a hybrid compound that exhibits similarity both penicillins and cephalosporins. So this is the penicillin nucleus, and this is the cephalosporin nucleus. You see this. This is 1, 2, 3, 4, 5. So N is at the 4th position here, where this is 1, 2, 3, 4, 5, 6, and N is at the 5th position here. That's how the O also changes from 7th position to the 8th position. And these are the penem classes, penems and carbapenems. So this is the difference between the two, but both are beta-lactams. So this is the faropenem that we are going to discuss today. And these are the carbapenems like biapenem, which is a newer molecule that has recently come in the market for as a newer antibacterial agent available for us. Ata, Dori, Imi, Miro are there since long. So coming to discuss about the faropenem, you can see the rings about every one of them, how they differ, so that you will understand what is the structural difference between these penems. So the faropenem particularly consists of 4-membered beta-lactam ring fused to a 5-membered sulfur-containing ring with a double bond C2 and C3. So double bond C2, C3, which fuses this 4-membered beta-lactam ring to the 5-membered sulfur ring. And there is a side chain at C2 responsible for both stability and activity. So additional rings as well as stability and activity is also there. It has a smaller size of 397 Daltons and higher affinity for many penicillin binding proteins. So efficiency is also higher, size is smaller, and there is additional ring provided. So that's how it is a better penetration in the bacterial cell wall, which we want when we want our antibiotics to work. And it has a broader spectrum, increased antimicrobial activity, which we are going to discuss further. So to discuss about the stable against beta-lactamases, you can see penicillin, cephalosporin, imipenem, and then there is a faropenem. So it is stable against, so this faropenem is stable against hydrolysis by almost all class A, C, or D lactamase producing organisms, including those producing ESBL, MC, beta-lactamases. ESBL and MC are a little dangerous because these are extended spectrum beta-lactamases and MC beta-lactamases, which usually makes the higher end antibiotics also not working properly. So this is stable against hydrolysis by almost all these agents. Also, hydrolysis by metallo-beta-lactamase is 5 times less than that for the imipenem. So this is the difference how, and this makes it more stable against beta-lactamase as compared to other agents. If you see the spectrum of antibacterial spectrum, it has a broad antibacterial activity against both aerobic, anaerobic, gram-positive, gram-negative. This is what we want. So right from Streptococcus pneumoniae, which is the commonest cause of pneumonia in any patient presented to you in OPD, Pyogenes, Saprophyticus, Epidermidis, then Staph aureus, Enterococcus faecalis, Neisseria gonorrhea, meningitis, Escherichia coli, Faecium, Klebsiella, Proteus, Citrobacter, Salmonella species particularly, Providentia, Bacteroides. These all the gram-positive and gram-negative bacteria that it is active against. And in vitro studies of faropenem has shown the number of isolates and the MIC range. This is given what is its activity against gram-positive bacteria, and also it has activity against gram-negative. These are the number of isolates, and then whole range of gram-negative bacteria are given, and these are the MICs basically in milligrams per liter, 0.5, 0.5. Against Monoxella catarrhalis, E. coli it is 0.25. So this is how it is also active against the gram-negative. So gram-positive, gram-negative, and coming to anaerobic bacteria like Clostridium perfringens, difficile, Bacteroides fragilis, and Peptostreptococcus species. So these are also having a very good MIC values as far as killing them is concerned. So Faropenem is a 4 to 8 fold. So according to this study, it is 4 to 8 fold more active against penicillin resistant Staphylococcus pneumonia. So Staphylococcus pneumoniae, penicillin resistant, it is 4 to 8 fold more active. That is how it becomes agent of choice when treating these patients. And also Faropenem exhibits activity against beta-lactamase producing strains of Monoxella catarrhalis and H. influenzae. As you can see in this comparison study, in vitro activity of Faropenem and comparator against the gram-negative aerobe. So it has activity against beta-lactamase producing catarrhalis as well as H. influenzae. Coming to in vitro studies where antimicrobial activity of Faropenem, a new oral penem against lower respiratory pathogens, was studied in clinical microbial infect in 1999 by Anne Marches et al. They have studied 503 Streptococcus pneumoniae strains, including 29 low-level strains and high-level penicillin resistant strains. Also, 310 of H. influenza and 63 of Monoxella catarrhalis strains. Faropenem was found to be effective against most bacteria causing respiratory tract infection. So this is the study, and this is the proof of action of this antibiotic. Coming to this Journal of Infection and Chemotherapy, it's an original article showing susceptibility of various oral antibacterial agents against extended spectrum beta-lactam, ESBL producing E. coli and Klebsiella pneumonia. The study measured the antimicrobial activity of 14 currently available oral antimicrobial agents such as ESBL producing E. coli, Klebsiella, isolated from urine tract, blood, and others. So higher susceptibility rates with Faropenem, 99.4% for E. coli and 97.3% for Klebsiella pneumonia was demonstrated. And this was again done in 2014 in Journal of Infectious Chemotherapy. So this is how even in a higher studies basically done in these journals, it was shown to be 99.4% effective in E. coli and Klebsiella. I think E. coli, Klebsiella are the biggest problem of managing any septic patients in any ICU all over the world, and I think in India, Klebsiella is causing more problem than anyone else. So if you see higher susceptibility rates with Faropenem, as we had discussed in that paper, and this is the proof of it, antimicrobial susceptibility of ESBL producing E. coli. So even if it is ESBL, Klebsiella, or E. coli, then Faropenem is again, we can prescribe in a oral form in the OPD basis. Now, what is the clinical evidence of Faropenem? Let us study that also. So this was a study of 10,000 odd patients as a double-blind phase 3 intent to treat trial with 618 adults with pneumococcal pneumonia were randomized to receive 10-day oral treatment with Faropenem of 300 mg twice daily or amoxiclav 3 times daily. As you can see, amoxiclav and Faropenem minoxidil clinical cure rates with Faropenem was comparable to that of amoxicillin and clavulanic acid. Then another study which they have compared a double-blind 827 patients with acute exacerbation of AECB patients were randomized to 5-day oral therapy of Faropenem versus now azithromycin, and clinical cure rates here also was comparable to that of azithromycin. So they have compared the oral agents available, other agents available, and if you see this study done in UTI, in urinary tract infection, treatment of acute uncomplicated cystitis with Faropenem for 3 days versus 7 days. So what is the difference? It's a multi-center randomized open label control trial, again published in Antimicrobial Journal of Chemotherapy in 2014, and in which total 200 female patients with cystitis were enrolled and randomized into 3-day or 7-day treatment groups, N being 97 and 103, it is in 2 groups. At 5 to 9 days after the completion of treatment, 73 and 81 patients from 3-day and 7-day groups respectively were evaluated, and they found 3-day treatment eradication and 7-day treatment eradication. So Faropenem showed a superior rate of clinical and microbiological response in these patients with 3-day treatment. Also, an E. coli strains resistant to fluoroquinolones or cephalosporin showed high susceptibility to Faropenem, which is found in this study. Coming to this study where the efficacy of Faropenem for patients with acute cystitis caused by ESBL producing E. coli was studied, and again they found the outcomes all had a cured outcome. So Faropenem achieved clinical cure in patients with acute, uncomplicated or complicated cystitis caused by ESBL producing E. coli. So may it be respiratory tract infection, may it be urinary tract infection, may it be ESBL E. coli or Klebsiella, Faropenem was found to be useful in all these studies that we have shown. Now, the biggest challenge in using any antibiotic or any agent to kill the bacteria is basically fear of developing resistance. We know we are going towards an era where we don't have any new antibiotic in the pipeline for say years to come now, but that's how I think we should try and utilize the current antibiotics so that we'll not produce the resistance to any of the antibiotics that we already have. That's when our responsibility as clinicians increases, because using the right antibiotic for the right infection, for the right dose, and for the right timing with the right combination has to be done. And obviously, when you know that there is no infection, you should not use any antibiotic, because empirical use of antibiotic is not going to help anyone. And if you use antibiotic judiciously, then only whatever we have, we can use it properly, and it can save future of our patients. Because WHO has already given a warning: bad bugs, no drugs. We know that there are certain bugs which have become resistant to many of the antibiotics that are currently available, and we are left with very limited options. So we need to be very careful while using antibiotics as far as proper dosing, other things are concerned, because resistance to beta-lactam antibiotic is very common. So antimicrobial resistance is a global health concern, is one of the top 10 global public health threats facing humanity. For common bacterial infections, including UTI, sepsis, sexual transmitted disease, RTIs, and some form of diarrhea, high rates of resistance against antibiotics frequently used to treat these infections have been observed worldwide, indicating that we are running out of effective antibiotics, as I mentioned already. CDC's antibiotic resistant threats in United States 2019 report more than 2.8 million antibiotic resistant infections occurs in the US each year, and more than 35,000 people die as a result. So it is going to be one of the challenges in coming future to manage this patient, because if the bacteria is not sensitive to any of the antibiotics, then I don't know what we'll do. So this is what I was talking about, development of resistance of beta-lactam antibiotics, and these are the several mechanisms that are involved in it. First is the restricted access to targets. You see, these drugs are going to access this target, and then it is going to act and then come inside the cell wall. But the membrane penetration barrier gets restricted, is one of the mechanisms how the beta-lactam antibiotics become resistant. Then second is the alteration in penicillin binding proteins, as we discussed initially how the beta-lactam antibiotics act. So these penicillin binding protein gets altered. This is second mechanism. And third, and very important, is presence of drug degrading enzymes like beta-lactamases, which makes the current antibiotic also ineffective. So these are the beta-lactamases where there will be degradation of the antibiotic, and the whole process of action of the antibiotic will be prevented. Bacterial cell wall will not be lyased, and the same antibiotic will not be effective. So we need to be very cautious in using these drugs, and proper indication, proper dosing has to be done so that we can prevent this development of resistance. Now, what are the beta-lactamases? These are the enzymes produced by bacteria that provide multi-resistance to beta-lactam antibiotics. So I will be showing one diagram where we try to discover one antibiotic, and the bacteria has become smarter than us, and then they try to develop resistance against it so that they can win the battle. And this battle is ongoing. We are battling against the smallest creature on this earth, but I think at times we are not succeeding against managing this sepsis patient in the ICU also. We have quite a bit of mortality whenever it comes to managing sepsis. So these are the enzymes, the beta-lactam enzymes. They hydrolyze and destroys the beta-lactam ring of beta-lactam antibiotics and makes the antibiotic ineffective. So these are the beta-lactamases, and then they destroy this beta-lactam ring where this antibiotic will get hydrolyzed, and then the bacteria will not be killed. There is an amber classification of beta-lactamases. There are a lot of beta-lactamases available: class A, B, C, and D. Class A and D, there is penicillinase, cephalosporinase, extended spectrum beta-lactamase, shortly called as ESBLs. And then there are metallobeta-lactamase, MBLs, carbapenemase, and AMC beta-lactamase. So ESBLs are extremely broad spectrum beta-lactamase enzymes which can destroy a very high level antibiotic also. Carbapenemase will destroy the carbapenem, and then the same drug will not be effective. It is found to be in a variety of enterobacteriaceae, which is a major concern in treating patients of sepsis in any of the ICUs. So this was the diagram that I was discussing. Since 1940s, we are trying to discover the antibiotic like penicillins, and then bacteria become smarter. They develop beta-lactamases. Then comes 1950, where penicillin G, procaine came, then methicillin, and ampicillin, monobactams, ticarcillin, all these agents started coming, and beta lactamases and other agents started developing. So if it is methicillin, then the MRSA came to destroy it. You can see MRSA here. So each antibiotic is followed by development resistance by the bacteria, and that is how we need to be very careful in treating these patients. So then this is the MRSA. 1960, as I was mentioning, methicillin aya, then MRSA came to destroy it. Then broad spectrum beta lactamases to destroy. So initially it was just beta lactamase, then it became a broad spectrum beta lactamase. We discovered carbapenicillin and carbapenems, and they came out with ESBLs. So the battle is ongoing. And then carbapenemase in 2000, which makes the carbapenems ineffective, and so on and so forth. So extended spectrum beta lactamases is another challenge. It's a group of plasmid mediated, diverse, complex, and rapidly evolving enzymes that are posing a major therapeutic challenge today in the treatment of hospitalized and community-based patients. ESBLs are primarily produced by Enterobacteriaceae family, which is a gram-negative, particularly Klebsiella and E. coli. These are very notorious organisms. And then non-fermentative gram-negative like Acinetobacter baumannii and Pseudomonas. These are, again, Acinetobacter is a deadly organism where it's a hospital-acquired organism which spreads once somebody gets an Acinetobacter in the ICU. There is an epidemic of that. If you don't control within time, you have a lot of mortality. So infections due to ESBL producers ranges from uncomplicated UTIs to life-threatening sepsis. ESBL induces resistance to most beta-lactam antibiotics such as penicillins, cephalosporins, carbapenems, and monobactams. ESBL producing organisms remain an important cause of therapy failure with beta-lactam antibiotics and have a serious impact on infection control practices in the hospital. Now, what are the risk factors for acquiring a hospital-acquired associated ESBL infection? We see a lot of patients, they come for something else and then they end up developing hospital-acquired infection. And these are the risk factors. Any patient having ICU admission for any purpose, particularly those who come for the post-operative observation, also they are at risk of developing, because the length of stay in the ICU increases. There are more chances that patient can develop hospital-acquired infections. Renal failure is another important thing. We know India is a hub of diabetes, and then associated uncontrolled diabetes can cause underlying diabetic nephropathy, CKD, and then the renal failure makes them a risk factor for acquiring an ESBL infection. Burns. Total parenteral nutrition is again one of the risk factors. Any indwelling catheters or urinary catheter, central line, hemodialysis catheter, or any catheter for long duration is another risk factor. And third generation cephalosporin use is another important risk factor which can make them prone for ESBL infections. So what are the key characteristics between hospital and nosocomial infection? How can you differentiate? Usually community onset organisms are E. coli and hospital onset is usually Klebsiella, but I'm not saying that E. coli cannot be hospital acquired. E. coli also can be hospital acquired. Type of ESBL in both are different. Type of infection, community acquired, usually UTI, also bacteremia or GI infection. And if it comes from hospital, then intra-abdominal, respiratory, urinary infections. Molecular epidemiology isolates, not always they are related, but isolates usually related, and that is outbreak. And usually you can pick up this in the cultures. That's why I think sending cultures is an important aspect of treating any sepsis for that matter before starting antibiotics, because that is what is going to guide your therapy after 3 days, whether you are going to escalate, de-escalate, or what are you going to do. So what are the clinical implications of all these things? ESBL producing bacteria are associated with severe infections such as bacteremias, intra-abdominal infection, UTIs, particularly in the community setting, and respiratory infections. Inactivate cephalosporins, rendering empiric antibiotic therapy ineffective. If you start with cephalosporins and these are the risk factors, then this is not going to work. That's why it is said usually you should start with a higher cover whenever you are faced with a patient who has comorbidities, who has multiple risk factors for ESBL developing organism. You should not start with cephalosporin, but you should go higher up. ESBL genes have the propensity to jump between the organisms and thus leading to outbreak of infections. And it have the ready capacity to acquire resistance to other antimicrobial classes. So like quinolones, tetracyclines, cotrimoxazole, trimethoprim, and aminoglycoside, which further limits the therapeutic option. So if you want to try to combine two agents together, then they have a propensity to acquire resistance to other antimicrobial classes as well. So that's why we need to be very careful while treating these patients. How do you treat them? Carbapenems are the treatment of choice for serious infections due to ESBL producing organisms. Yet carbapenem resistance isolates have recently been reported. ESBLs are becoming increasingly complex and diverse, and their detection is becoming increasingly challenging for clinical microbiological laboratories. Indiscriminate use of carbapenems may select resistance. That's how I'm telling that indiscriminate use of antibiotics wherever it is not indicated, where we know that source is something different, where we know that it's a gram-positive bug that is more commonly causing infection in the skin and soft tissue. We should not choose gram-negative antibiotics in these patients unless there are certain indications. So indiscriminate use of carbapenems may select resistance to these key drugs, thus sowing seeds for significant therapeutic problems and challenge to arise in the future. ESBLs are inhibited by beta-lactamase inhibitors such as clavulanic acid. So if you want to break this ESBL and find out something against it, then you should combine beta-lactamase inhibitors along with the beta-lactams. So use a beta-lactam and beta-lactamase inhibitor combinations as workhorse empirical therapy for infections suspected as being due to gram-negative bacilli may facilitate control of the ESBL product. So if you combine a beta-lactamase with the beta-lactam, then you can, I think, facilitate control over ESBL producers. So resistance to carbapenems has been seen in some strains of Klebsiella E. coli in the form of carbapenemase. So APC, that is Klebsiella producing carbapenemase, or NDM, that is New Delhi metallobeta-lactamase, which is a agent given by India to the world. That is what is contemplated, and there is an increasing concern on overall incidence of carbapenem therapy. ESBLs are inhibited by classical beta-lactamase inhibitors, and those are clavulanic acid, sulbactam, and tazobactam, and now we have another thing, avibactam. So beta-lactams have been among the most successful drugs for the treatment of bacterial infections caused by numerous species for the over 60 years, but they have been plagued by the problem of increasing clinical resistance. So development of new beta-lactam antibiotics through structure modification of existing beta-lactam is not keeping in pace with the resistant development. That's how I think it is not a wise idea to just keep on researching about beta-lactam, but beta-lactamase inhibitors, if you try to add on that, then so overcoming resistance of beta-lactam antibiotics, and then there are two options as I was discussing: design new beta-lactam, which is not possible now, or combine a beta-lactam antibiotics with inhibitors of beta-lactamase enzymes. So combination therapy will account for the most common use of beta-lactam antibiotics in the future, and most successful approach employed to date to extend the utility of beta-lactam antibiotics, pair the antibiotic with the inhibitor, like we have now ceftazidime with avibactam, which is said to be a better agent to treat any multi-drug resistant Klebsiella or E. coli for that matter in the ICU. So ceftazidime is an old antibiotic, but avibactam makes it more powerful, and that is how I think this combination works better than starting cholesterol or meropenem to patients who you think are very septic in the ICU. Discussing about this faropenem sodium of 200 mg and potassium clavulate of 125 mg combination. What is the benefit of combining with potassium clavulate? It helps to overcome antibiotic resistance in bacteria that secretes beta-lactamases. It helps to restore the original antimicrobial spectrum of the original molecule. It broadens the antimicrobial receptor, and ESBLs are inhibited by classical beta-lactamase inhibitors such as clavulanic acid. And that is how I think if you combine faropenem with potassium clavulate, it becomes more stronger to act against the bacteria. Clavulanic acid is widely used in combination. We have been using since 1984 as a combination of the amoxicillin and the brand Augmentin that many of us use. It was the best-selling antibiotic in 2001, demonstrating the effectiveness of beta-lactam inhibitors approach in the clinical setting. So DCGI has approved, these are the combinations of clavulanic acid, amoxicillin, cefodoxime, ticarcillin, cefotroxil, cefuroxime, cefodoxime, and cefixime clavulanic acid. So these are all combinations which are approved. Now, what are the indications when you would like to? So lower respiratory infections like bronchitis, bronchiolitis, and pneumonia, where you find that there will be a combination which will be working better than the beta-lactams alone. In skin or skin soft tissue infections like erysipelas, cellulitis, cutaneous abscesses, wound infections, surgical site infections, and diabetic foot ulcers. And in sequential antibiotic therapy, conversion from intravenous. So whenever you want to discharge a patient which is already on intravenous therapy, you want to give something oral for 5 to 7 days till the follow-up comes, or the patient should get covered when he's at home, then definitely you can start these on discharge. And dosage is 1 tablet thrice a daily if you are using 200 mg. Dose duration of treatment depends upon the severity of infection, clinical response, age of the patient, symptoms, and bacteriology findings. So this is definitely important to dose it appropriately as per the creatinine clearance. You should always have creatinine clearance or serum creatinine value of these patients, because you will have to dose it accordingly. It should not cause any nephrotoxicity. So what are the precautions as we discuss here? Hypersensitivity to penicillins. You should ask this history to the patient. Is there any family history of atopy? Is there a renal insufficiency, which is a very important factor while prescribing any antibiotics for that matter? And poor oral intake or poor general state is another thing that will help dosing it appropriately. What are the adverse effects? Generally, these are the antibiotics which are well tolerated, but as we all know, antibiotic-associated diarrhea is very common. Then abdominal pain, loose bowel movements, nausea, and rash is one of the few rare things that are reported. Usage in special population elderly, start with a low dose and monitor the patient for undesirable side effects. You should monitor the renal functions and the efficacy and the clinical state of the patient also. Pregnancy safety is still not established. Lactation is Faropenem excreted in the milk, so usage should be decided based on the risk-benefit ratio, how much the mother is going to get benefit out of it and how much the child is going to suffer if it gets secreted in the milk. Pediatric population is still not studied, so not a drug of choice in pediatric population. Renal impairment, as I discussed, use cautiously as plasma concentration of the drug is increased whenever there is renal failure. So I think you have to dose it half the normal dose in these patients. There are drug-drug interaction, but very few. Imipenem and cilastatin sodium combination, concentration of Faropenem in the blood increases. But I don't think anybody would use this oral plus IV combination together. Furosemide, kidney toxicity to the Faropenem increases because if the furosemide is used and there is pre-renal acute kidney injury, the creatinine value is high, serum creatinine is high, the creatinine clearance value clearance becomes less, then I think the toxicity is more. If you combine with sodium valproate, if somebody is on that, then chance of recurrence of epileptic fits are there. So that's how this history is important. You should not combine with sodium valproate or patients who already are schizophrenic because recurrence of epileptic fits was found to be more. And with this, I thank you all for your kind presence and listening to me. I'm open to questions, if any, by the audience. We can take the questions. Mahesh?
Yes, sir. I have already posted in the chat box regarding the questions. If at all any of them, any of the participating doctor have any kind of question they can ask. So far, I have not received any question. I'm just checking that. No, I have not yet received any question.
Okay.
All participating audience can put their questions they have in the chat box. Doctor will address all questions and answer all the questions. So, sir, I think the questions are not there. Yes, there is one question.
Lactating mother for endocrine species UTI. So that is what we discussed actually, and we had one slide for the specifically for that. The risk-benefit ratio has to be discussed before we start considering this antibiotic for lactating because it is secreted in the breast milk. So if the risk-benefit ratio is in favor of using, then definitely you can still use. But a word of caution because it is secreted in the breast milk, and it is not a drug of choice for any pediatric patients. It is not studied in pediatric population. That's how I think the restricted use in lactating mother as well as pregnant women. Yeah, so Abhijit, I think that answers your question.
Any other question? You can directly ask to sir. If at all any other question.
So apart from whatever we have discussed, I would like to just add a comment to the viewers. If you happen to have a patient of multi-drug resistant tuberculosis and if the treatment options are limited, then I have used Faropenem for say more than 9 months also in these patients of MDR-TB, and I found a very good result if you use this as a second line agent to treat tuberculosis. So there are reports and case studies where Faropenem is used as a second line MDR-TB drug, and it was found to be useful. So this is another indication I think you can add on if you find any patient of MDR tuberculosis where the oral drug options are limited or the patient is not tolerating a single drug for long term, then you can use Faropenem there.
Any other question, viewers? I would request you to put your questions in the chat box. You can directly ask.
Or you can
by
unmute
unmuting.
and send a
Yes.
comment also, nothing, something like that.
So there is a question.
So which of the antibiotics are combined with carbapenems to prevent drug resistance? So as we were discussing about the beta-lactamase inhibitors like clavulanic acid or tazobactam or avibactam currently, actually, we don't have meropenem with avibactam available in India. That is what the combination is going to come in the future to save our meropenems from getting destroyed. So whatever carbapenems are there, if they are getting destroyed with carbapenemase, then you have to combine with the beta-lactamase inhibitor. And I think that will be an appropriate combination to prevent resistance development with carbapenems. So I think that answers.
Any other questions? All participating audience.
Meropenem and EDTA have any role to prevent drug resistance? Yeah, this is a newer option that is coming, EDTA, and we know that it's a chelating agent, EDTA, which usually helps in increasing the penetration of the current antibiotics, and the same antibiotic which is resistant becomes more effective. This is an option available now, and we are using. There are trials and studies in favor of that. So I don't think it will prevent the resistance development, but it will definitely help increasing the penetration of the antibiotic inside the cellular membrane so that it has its action better than what previously. So that's how I think this EDTA combination has come with ceftriaxone sulbactam with EDTA. It's available in the name of Iloris. And I think that is how simple ceftriaxone also becomes more effective in managing these patients. Did Faropenem can be used Pseudomonas infection? Yeah, as we have seen the gram-negative and gram-positive cover. So Pseudomonas is a gram-negative bug basically. So it has been shown be effective for E. coli, Klebsiella as well as Pseudomonas.
Any other question
or any comments anyone would like to give, or somebody can mention their experience
any
also
other
with this
question?
molecule. Mesh, you are not audible.
Yes.
Yeah, now it's okay.
So is if at all any experience anyone wanted to share with the molecule, or any kind of comment you wanted to put, you can directly ask to sir. You can unmute yourself. You can ask to sir, or you can put it in the chat box also. Sir, I just wanted to, out of curiosity, just wanted to understand what are the possible, use of Faropenem with clavulanic acid in further, understanding specifically in this current COVID situation, or in the current scenario where there are many more challenges across medical fraternity regarding the increased respiratory resistance. What is your opinion about that, sir?
Yeah, post-COVID, we know that post-COVID illness patients, or whenever treating COVID also, after somebody gets a COVID infection and 4 to 5 days down the line, they start getting fever again, and their other inflammatory markers go up. So we know that there is secondary bacterial infection happening. And so definitely, if somebody, if the patient is coming on an OPD basis, I think Faropenem with clavulanic acid is definitely a very good option. We have discussed about the population who will be at risk of developing a ESBL producing organism or carbapenemase producing organism. What are the risk factors? So all those who have kidney problem, uncontrolled diabetes, all those who are immunosuppressed, you should definitely add clavulanic acid with Faropenem, because that will make the primary molecule more stronger and more efficacious to manage these infections. So all complicated UTIs, LRTI, intraabdominal infection, you can upfront start using the combination. So I think if you are done with the questions, you can.
Yes, sir. I think we are at the end of the session. We can end the session. So Shrikant, yeah. So good evening. On behalf of Zydus, I, Mahesh Marathe, would like to thank you all for your active participation. I would like to thank Dr. Harish Chafle for his wonderful presentation. This expert talk symposium was on drug review of Faropenem with clavulanic acid and in the management of respiratory health. It was indeed our privilege to listen you, sir. Last but not the least, my sincere thanks to entire participating clinicians and all those who had had queries, without whom the event would not have been possible. It goes without saying that we will continue to rely on your affection and support now and hereafter. Thank you, and have a great weekend. Good night and stay safe.
Thank you all. Thank you, Mahesh, and thank you, Zydus, for this.
Thank you, sir. Thank you, sir. It was indeed very great to see you, sir, and great to listen you, sir, all your experience regarding the respiratory tract infections and the possible outcomes regarding and the kind of challenges that we face recent days. That is very much informative. The information, in fact, I being a learner, I was very much happy to listen you, sir. It was very much elaborative that you have demonstrated all the points, aspects for respiratory health, sir. We would like to connect with you, sir. I would like to meet you in person also, if at all possible. Definitely will come there. I'm from Mumbai only, so I'll be able to meet you in person.
Okay.
Yes, sir.
Thank you. My pleasure.
Thank you, sir. Thank you for being with us, sir. Thank you.